Okay, so I'd like to welcome everybody for what I'm sure is going to be a really terrific talk, relevant at so many levels for so many groups of people. So before we get started, though, I'd like to tell you a little bit about who we are. We started as part of the APA interdivisional task force on the pandemic. And we're a working group that addressed people working in hospitals and other medical settings. And then when Dr. Patricia O'Gorman joined us, she, which was early on, I asked her to be my co-chair, and she is a specialist working with trauma and addictions. So, we have really several resources. Next slide, please. So we have a website, resilienceincovid.us, and I encourage you, we have started out putting resources there, but then when we developed our own, we started putting them there. And one of our resources is our blog called Psychological Trauma, Coping and Resilience, COVID-19 and Pandemics. And we have, even though we started during the very beginning of the pandemic, March 2020, we now are realized we're the only working group that has continued because we realized that we're now just in a whole different phase, and there's still many, many issues to be addressed. And the blogs are written primarily by our group of very sophisticated group of mostly mental health practitioners, mostly, I guess we should move to the next slide. Mental health practitioners, mostly psychologists, but not all. We have some social workers. And then we have people such as Jen, who I call our linchpin, because she handles all the technical things. And we have some people with lived experience of traumas of various types. Next group, please. Next slide. Now we have the long COVID group. We've split off so that we now have two subgroups, and one is the long COVID group. And that started at the quite early on, and the co-chairs, you can see the names there. And okay, next slide, please. Then there's the ICU group, of which our speaker is an illustrious member. You can see his name there with all those many letters that I don't know what they are. And so we are addressing something that has been there all along, trauma in the ICU, but it took the pandemic to really make it so that everybody knows, right, about the terrible things that the profoundly stressful / traumatic experiences that people can have in the ICU. Now we have the next slide, please. We have some upcoming talks. And if you scan, you can you will be able to register. We always send these things out in advance, but take a look at that. The first is on May 17th, which is next week. Pandemic burnout in the staff of a hospital, longitudinal study and interventions for burnout. So I think that is really important. And then on the 2 weeks after that will be our last in this speaker series until the fall. And that will be Dr. Ken Prager at Columbia. same institution that Dr. Sladen is from. And he's going to talk about the corporatization of American medicine and how it leads to physician burnout. Okay, next slide, please. Now I'm going to turn it over to Dr. Ruth Jaffe, who is the one who found Dr. Sladen. Okay, Ruth.
Thank you, Maureen, and welcome everybody to this wonderful webinar that we have here today with Dr. Robert Sladen, who Maureen has mentioned is a member of our subgroup, the ICU group, and a happy reality that has become. Dr. Sladen is Professor Emeritus of Critical Care Anesthesiology at Columbia Medical Center, and he's boarded in anesthesiology and critical care medicine. He is also a fellow of the American College of Clinical Care Medicine and is a key member, I would say, very pivotal member of our subgroup, the ICU group. In 1997, Dr. Sladen joined Columbia University Medical Center, serving as medical director of the cardiothoracic and surgical intensive care units. Prior to Columbia University, he was on the faculty and practiced cardiac anesthesiology and critical care medicine at Stanford University in California and at Duke University Medical Centers. Dr. Sladen has received many awards, including a Lifetime Achievement Award from the Society of Critical Care Anesthesiologists, the Distinguished Service Award from the Society of Cardiovascular Anesthesiologists. He was elected Physician of the Year at Columbia University Medical Center in 2015 and is an emeritus member of the Columbia University College of Physicians and Surgeons, the Academy of Clinical Excellence in 2019. I'm greatly honored and very pleased to introduce to you Dr. Robert Sladen.
Well, thank you very much for that kind introduction, Ruth, and also my gratitude for introducing me to the ICU group. And it's really been a privilege and a great pleasure to have participated with you and starting to get to know so many members of your group. I'm going to be talking about critical care at the end of life. When is enough too much? Just as a background, that MBChB is a medical degree from the University of Cape Town, South Africa, which is where I grew up. It's an MBChB because it's an undergraduate degree, and it's actually the Scottish degree because the founding professors of the University of Cape Town all came from the University of Edinburgh. So if you know anyone from Edinburgh, they have the same medical degree. The others are the member of the Royal College of Physicians, which is an internal medicine degree in the UK. FRCPC is the anesthesia degree from Canada, and the FCCM is the American College of Critical Care Medicine. So a bit of a world citizen, and that accounts for the funny accent. So what I'm going to really do today is to talk about a number of aspects that reflect my career in critical care medicine from a physician standpoint, and we'll see how that unfolds as we go along. But when we talk about critical care at the end of life, the first question is really, when does life end? And for centuries, life ended when we stopped breathing and our heart stopped beating. After the polio pandemic in the early 1950s and the advent of mechanical ventilation, we had the emergence of intensive care units where patients were able to be kept breathing with mechanical ventilation, even though they weren't spontaneously breathing anymore. And this kind of gave rise to what one might call a somewhat artificial definition, because it was dependent on that. But back in 1981, was the Uniform Determination of Death Act in the United States. And you can see this was a collaboration of multiple different associations that defined death as the irreversible cessation of respiratory and circulatory functions or the entire brain, including the brainstem. So this has been known as the UDDA, and we today very much talk in terms of circulatory death, where the heart stops beating, and brain death, when there is extensive damage to the brain, including the brainstem. And the sense is that the body cannot function in its integrated way without these brain activities. However, it is possible for patients to continue to live without brain activity. And although it was accepted that in many cases the heart would stop beating within a few days or weeks, there certainly have been cases of children undergoing growth, even entering puberty, and others being kept alive for months or even years. So this is a difficult realm that we've gone into. In terms of the determination of death in the USA, this map shows you that these United States may or may not be united depending upon what we're talking about. And just to kind of summarize this, all 50 states recognize the UDA concept of brain death, but the interpretations vary dramatically. 9 require life support to be in place for brain death to even be evaluated. Virginia requires cardiorespiratory death as well. Arizona simply requires acceptable medical standards and doesn't define exactly how brain death should be determined. New York and New Jersey require hospitals to accommodate moral or religious objections to brain death. And in a recent case in New Jersey, a judge upheld a family's objection to even having brain death determined. And brain death is determined by clinical criteria, mostly an apnea test, so that the patient is withdrawn from ventilatory support, and a certain period of time goes by, and the carbon dioxide is measured. And if the patient doesn't develop spontaneous breathing after a period of time, that is a very important consideration for brain death. Here's a report of a young man in his 30s in Toronto who actually suffered clinical brain death consequent to just overwhelming asthma. And his Orthodox Jewish family wanted the brain death son's death certificate rescinded because their faith will not accept that he is deceased. And indeed, the court granted an injunction to keep the man on life support, and he actually lived for another 6 months after this period of time before his heart stopped beating. So you can see that this is an issue that is going to need to be encountered when we're dealing with patients at the end of life in intensive care units. And I'm going to come back to some suggestions for how to do this as a caregiver. Let's take a step back and as medical caregivers, the question I'm going to ask first is, can we set realistic expectations for patients and their families? And this is really very important for anybody who is admitted to hospital with a life-threatening condition or undergoing major surgery. And there's I think a really very cogent editorial. This is 2 doctors from the Czech Republic. It's a short and concise editorial, but they phrase, I think, some important questions. Firstly, which patient subgroups may experience substantial benefit from ICU interventions? This is a question that really is a wider one than we can really discuss today. A question that is seldom asked is, what is the likely patient trajectory after discharge from the intensive care unit? Can we provide clear and honest information about risks versus benefits? And what are the patient's wishes and personal values? And it's these last two that I really want to try to focus on in our discussion today. So a couple of things to keep in mind, that expectations of outcome should be patient-based and not caregiver-based, but they differ in priority and value by nationality and culture, by religious beliefs and philosophy, which we've already alluded to, by intrinsic patient values, by the patient and family hopes and fears, and by caregiver experience and bias. And so we really need to take a look at the big picture when we're talking about setting expectations. Here's an article, for example, that was published in The Economist back in 2017. And what they did was they interviewed people from the United States, Italy, Japan, and Brazil. And they asked the question, thinking about your own death, how important is the family not being burdened financially, being comfortable without pain, and so on and so forth, and living life as long as possible? And you can see that most nationalities were sort of grouped in the 65 to 90%. But when it came to living as long as possible, there was a dramatic difference between the expectations of the Japanese respondents. Only less than 20% was it extremely important to live life as long as possible, whereas for the Brazilians, it was very important. So even something as simple as how important is it for you to live as long as possible may vary among different cultures and backgrounds. There are disparate priorities that are really stated very well in this article by my colleague Shala Siddiqui, who works up in Boston. And what she has done here is to compare the emotional investment in outcome versus the consideration of professional outcome measures. Now, clearly, the patient and the family have the greatest emotional investment in the outcome, and they are the least concerned about professional outcome measures of how the hospital is doing. On the other hand, the hospital administrators are very concerned about the outcomes in the hospital, but they would have the least emotional investment in individual patients and families. ICU nurses who are sitting at the bedside will have some involvement in outcomes clearly in their practice, but they're the ones who are going to be the most emotionally investment because they're at the bedside 24 hours a day. Surgeons will have the investment in their patients, but they'll have multiple patients that they're taking care of, and they're very concerned about their outcomes. And the intensivist is somewhere in between. So you can see even among caregivers, there are going to be different priorities depending upon one's proximity to the patient on a moment-to-moment basis and looking at the larger picture of how the unit or the hospital is doing. So the next question is, well, who should set these expectations? And very importantly, some of these expectations must be set by the patient and the family themselves. And this is where pre-admission documentation is so essential. The importance of having an advance directive laying out what one's considerations would be in a life-threatening situation through a living will, creating a durable power of attorney or a healthcare proxy with a loved one with whom you have shared your clear directives and who can act as your proxy and knows your wishes and values. There is an organization called 5 Wishes that can be very helpful to the lay public that I'll mention in just a moment. And another vehicle that I would draw your attention to, because I wasn't aware of this until relatively recently, and I don't think a lot of people are, is something called Physician Orders for Life-Sustaining Treatment, or POLST. And there's a website, polst.org, that is very informative. And as caregivers, I really believe we need to play a more prominent role in educating our community, which is exactly what your group is doing, but in the importance of documenting one's wishes prior to a major event that requires admission to hospital and resuscitation. This is the 5 Wishes website, and it's essentially a National Advanced Care Planning Program. And the way it's set up is that one is able to express 5 wishes. So the first wish would be to designate the person I want to make care decisions for me when I can't. In other words, this is equivalent to a healthcare proxy. The second is the kind of medical treatment that I want or don't want. This would be the living will of what kind of resuscitation one wants, or if any. The third would be how comfortable I want to be kept. A fourth would be how I want people to treat me at home, in a hospice, or in a hospital. And the fifth is what I want my loved ones to know about my wishes. So this is, I think, a very useful program, and I think it's incumbent on all of us to let those that we interact with know about it. What about this PULSE? Well, PULSE is a task force that is set at a national level, but the program is administered by the states. And in some states, it's actually called MOLST, the medical orders for life-sustaining therapy, as opposed to physician orders, but it amounts to the same. So what is it? Well, it's a series of orders created for patients with serious illness or frailty at risk to a life-threatening event. These orders are portable, so they're applicable across healthcare settings. This is especially important if someone calls 911 and the EMTs arrive, and unless there are orders to the contrary, they are obligated to start CPR, and the same when the patient arrives in the emergency room. The PULSE provides more detail about the level of care desired than a simple do not resuscitate, and I'll show you the form exactly. It complements, but it doesn't replace an advance directive, and it doesn't include designating a surrogate in this particular form. That should be done ahead of time. It must be signed by a physician, nurse practitioner, or physician assistant to be a valid medical order, and that could be utilized outside a facility and across facilities, and where possible, the patient or a surrogate should co-sign. So let's take a look at the PULSE, the Physician Orders of Life-Sustaining Treatment. And you can see it starts off with designating whether cardiopulmonary resuscitation should be attempted or not. And if the patient is not in arrest, then you go to the next medical interventions. And here, it really, I think, very wisely allows one to designate whether one wants full treatment, which is the primary goal of prolonging life by all medically effective means, or selective treatment, the goal of treating medical conditions while avoiding burdensome measures, such as intubation, mechanical ventilation with intubation, avoiding intensive care. And you can see that above is the option to have a trial period of full treatment. Selective treatment requests transfer to hospital only if comfort needs cannot be met in the current location. Or the third option would be comfort-focused treatment, the primary goal of maximizing comfort and without using any of the treatments mentioned in the full and selective, and request transfer to a hospital only if the comfort needs cannot be met in the current location. So you can see how specific this is with regard to the patient's needs, and it really does avoid the uncertainty that is a halo effect around so many of simple DNR orders. There are even indications for how one would want nutrition to be administered, and then there's information about the advanced directive, the healthcare proxy, and so on. So again, I will encourage all my physician colleagues and anyone else that I know who is a layperson to take a look at PULSE, because I think it's actually a very helpful and important document for those who are at risk. Now, our surgical colleagues have come up with ways to try to assess the risk and set expectations, and there are a couple of web-based sites. So, for example, the thoracic surgeons and cardiac surgeons have a database where they can calculate risk. And then more generally, the American College of Surgery and the Quality Improvement Practice has a surgical risk calculator, which Jen will put in the chat, called riskcalculator.fax.org. And the way these things work is that one enters a lot of information based on this questionnaire, and then there is a calculation made, and it's expressed like this. So you can see that if you go down, it gives a percentage risk of things like serious complications, pneumonia, readmission, discharge to nursing or rehab facility, and at the bottom, very important, a predicted length of hospital stay. Now, what I've put in here is a really sick patient. This is a patient who is going to simply have a foot amputation, probably for vascular disease with diabetes, but it's a patient who's totally dependent functionally. It's an emergent case. Patient's had recent infection, has insulin-dependent diabetes, and is on dialysis. And you can see that the risks are enormously high. And so the question is, how does the surgeon actually convey this? And how does the patient interpret this? I was personally at a conference between a thoracic surgeon and a patient who'd been referred in from another hospital by their family, who had a very severe lung disease. And the surgeon said, you know, look, if we go ahead and do a tracheostomy and keep the patient in the intensive care unit, there's a 90% chance that he will die. And the sister's response, it was immediate. You mean there's a 10% chance that he could survive? And they went ahead with it. And, you know, 10 days later, he expired after 10 days of very difficult management. So, you know, percentages are very difficult to interpret and apply. Here is a consent form that was created at Columbia for patients getting a ventricular assist device. And this is an artificial heart, in a sense, device that maintains the patient's life until they can get a transplant, or today, actually more meaningfully, for the remainder of their life. And the consent form reads, if despite all our efforts, a patient is no longer a transplant candidate or has no reasonable chance of surviving to leave the hospital on the ventricular assist device, we will discontinue the ventricular assist device, as it will, under these circumstances, no longer be serving the purpose for which it was originally placed. And I think that this is something that a patient and a family should be able to understand, and it sets the proper expectations that going forward. And I think this is really where the emphasis should be, as opposed to simply giving percentages that may be very difficult to interpret. We also have to be very careful how we even speak to patients and their families. This was a very interesting study examining what the word treatable means. And the scenario that was completely an artificial one was they gave a scenario of a patient with very advanced cancer of the biliary system that is, quote, treatable with palliative radiation. And a group of non-physicians thought that this was actually quite good news. It was a positive message about the patient's future, that it was treatable with palliative radiation. It implies hope that it would help the patient and the patient's life would be better. And they felt encouraged to follow the plan and pursue the treatment. Well, the physicians had completely different response. They saw this as an action-oriented concept. In other words, there's a specific intervention available that could treat a discrete problem, pain, but not the overall illness. And it didn't imply to them success, survival, or even an improved quality of life. Same word, completely different interpretations through non-physicians and physicians. What about decision-making by the surrogate, the patient's family? Well, we've made the transition, say, 30 years ago and longer, where we could call it a paternalistic approach, and that it still exists in certain situations, which is physician-directed, in which the physician would say, well, this is what we're going to do. And most times the patient and family would, yeah, whatever you say, doc, that's what happened. And then what we found was a complete turnaround where the medical team would say to the family, what do you want us to do? I've been in those kinds of meetings. And what do you do when the family says, we want everything done? What is everything? Who decides what everything is? If the physician believes that an intervention is futile and potentially inappropriate or unreasonable, should that be withheld? And if the patient is on a vasoconstrictor like norepinephrine, noradrenaline, what dose constitutes everything? We know that if we keep going up and up on that dose, we're going to really start causing harm to the patient. We're going to potentially cause gangrene of fingers, toes, tongues, and nose. I've seen this. We don't ask patients to decide about all the medical treatments that we're doing. We say we're going to do this and we say we're going to do that. And yet now we take the most important treatment as to whether we should resuscitate the patient or continue life support, and we're putting that on the family and making them make the decision. And that's a very, very important point. Darrell Abrams and his group at Columbia, who work in the medical intensive care unit, wrote this paper that was really about the ethics of decision-making patients undergoing extracorporeal membrane oxygenation, or ECMO. And one of the co-authors actually is the doctor who's going to be giving you the talk about physician burnout in a couple of weeks. So the point that Dr. Abrams makes is that if the patient is alert and sentient, we should defer to the patient's wishes. If the patient's not alert or sentient, should we defer to the surrogate's wishes? And makes the point that our primary ethical obligation as physicians is to our patient, not to their surrogates. In other words, what we need to do is try to ascertain what our patient's values are and what they would have wanted, and not what the surrogate wishes might have been. I've been in situations where the surrogate is somebody who is a niece of the patient who lives 3 states away and hasn't seen the patient in 15 years. And yet we're asking them to make life or death decisions. So really what we should be talking about today is what is called shared decision-making. And the focus should be to the family. What do you think your loved one would want? And that's why it's so increasingly important for us to encourage our patients and our friends and family who are not in the medical field to talk to their loved one, talk to their parents, talk to their grandparents about what their wishes might be, so they know going in what they are. So from a practical standpoint, how do we share decision-making? Well, here's a very important, I think, concept that is called the facilitated values history, because what it does is it says what functional outcome is most important to the patient. Is it independent physical activity? Is it full cognitive ability? Is it meaningful relationships? And make the point that a patient who feels that their health status no longer allows them to sustain meaningful relationships may decline life-prolonging measures, even if they could be kept alive. If they're not able to interact with their family in a meaningful way, this patient may decide, I just don't want to do this. On the other hand, a patient for whom physical autonomy is not crucial may accept a certain degree of technological dependence and impairment, such as a ventricular assist device or hemodialysis. And I think the message is that one size does not fit all. Every patient is unique, and we must interact with every patient depending upon what is most important to them. And those are the questions that we need to ask them and their family. We also need to take into consideration the stress that is placed on the family in this sort of situation, especially when their loved one is unable to interact. If they've had no prior dialogue with the patient about their preferences, this really undermines their confidence to be surrogates, and they may appear to be very direct about what they want, but we don't know what kind of stress and tension they're undergoing in having to do that. They also become stressed if there's inadequate physician-family communication and emotional support. And we should be cognizant that this difficult decision, when they go away and their loved one has passed, it could result in long-standing guilt, anxiety, and depression for family members about the decision they felt that they had to make. The term withdrawal of care is one that should really never be used, because we should never give the family the sense that we are going to abandon their loved one. Instead, what we need to project is that the focus of care is changing from the prolongation of life to the relief of pain and suffering, and use the term comfort care and not withdrawal of care. So in other words, we're going to emphasize that we're going to discontinue interventions that cause pain or discomfort, but won't affect the ultimate outcome. That we're going to really focus on treating your loved one's symptoms. And we need to recognize that symptom relief takes precedence even if it may hasten death. So in other words, if one is using morphine for patient comfort, and in the course of that, it happens to depress the patient's respiration so that they pass earlier, one is not going to be legally indicted for this. And in fact, American Medical Association ethics opinion has also stated there's no ethical difference between withholding and withdrawing life-sustaining treatment. In other words, the ethics between saying we're not going to intubate you and put you on a mechanical ventilator versus we're going to take you off the mechanical ventilator, there is no ethical difference between those decisions. One is not of greater value or lesser value than the other. Again, we need to recognize that many of the legal requirements are state regulated, and they vary dramatically. So the two extremes that I'll give you would be New York and Texas. So in New York, these are the state requirements for do not resuscitate, withholding or withdrawal of treatment. Direct request of a patient with capacity would be the preferred way to obtain this, or the request of the healthcare proxy designated legally in a patient without capacity. If there is no healthcare proxy and there's only a surrogate, a family member who's not the healthcare proxy and who makes the request, then it has to be added to by two physicians with the consideration that ongoing care would be extraordinarily burdensome. That has to be agreed. If there isn't a surrogate, then two physicians can make the decision with the statement that treatment offers no medical benefit because the patient will die imminently. And in the meantime, the patient through all this must have had an ethics consult. So this is the New York statute. On the other hand, there is something called the Texas Advanced Directive Act, which was passed in 1999, also known as the Texas Futile Care Law. So if the care team feels that the care they're providing for the patient is futile, they can actually inform the patient's family, who can participate in the ethics consult process, and they're able to consult their own medical specialists and legal advisors. The ethics consultation process provides a written report, and if the ethics consultation agrees with the physicians and the dispute remains unresolved, the hospital may transfer to another physician or institution willing to provide treatment for that patient. But if no provider is found in 10 days, the hospital and physician may unilaterally withhold or withdraw what they consider to be futile therapy. The family can appeal to a state court to grant an extension of time to find a willing provider of the disputed treatment. If the family doesn't seek an extension or the judge fails to grant one, futile treatment may unilaterally be withdrawn by the treatment team with immunity from civil or criminal prosecution. It was amended in 2015 to accept nutrition hydration. So you can see that depending on the state that you're in, the circumstances of being able to obtain a DNR order or withdraw life support when the patient is unable to give that themselves may be very different. So it's incumbent on us to find out what the state law is in the state in which we reside. Now, what is the impact on all of this on caregivers? And here's a study that really showed the importance of this. The term moral distress implies caregiver disagreement with team members or family about continuing life support. This is something that's not uncommonly felt by nurses who are at the bedside, dealing with the patient, dealing with their pain and discomfort, where the medical team want to keep going at all costs. And this is referred to by the nurses as therapeutic obstinacy, that the medical team simply won't give up, where it's clear that this is causing distress. And this can be have a very negative impact on caregivers. And there can be disagreement among physician aspects of the team as well. There is something called compassion fatigue or vicarious traumatization, and it's caused by repeated observation by caregivers of the physical or psychic pain of the patient and an empathetic engagement with sadness and loss. And this occurring repeatedly over days and weeks and years. And the symptoms are anxiety, intrusive ideas, a feeling of hopelessness, exhaustion, irritability, detachment, cognitive impairment. During the pandemic, this was exacerbated by caregiver isolation, the need for personal protective equipment, the depression on the outcomes, and it could lead to suicidal ideation and self-harm. And the most dramatic illustration of that was the suicide of Lorna Breen, who is an emergency physician who worked at Columbia Presbyterian. And this happened in April 2020. She had actually recovered from COVID. We don't know if she'd had any residual effects, went back to work, went back to 12-hour shifts in the emergency department at a time, as we all know, where the outcomes from COVID were devastating. And refrigerator trucks were pulled up outside major hospitals in New York City. Dr. Breen has been commemorated by the Lorna Breen Healthcare Provider Protection Act, which was signed into law by President Biden in March of 2022 to provide funding for help and therapeutic support for caregivers. And this is a website that I would commend to you, endacademy.ca. It's a Canadian website, but it provides support in the United States as well as Canada as something to explore for caregivers, for physicians, nurses, psychologists, anyone involved in the care of patients who is starting to feel stress or has colleagues that might be feeling stressed. And I really commend this to you. So in the last section, what I'd like to address is some thoughts about how we should interact with patients and their families in these very difficult situations. One vehicle that has been advocated by the Society of Critical Care Medicine is a smart pad-based patient communicator. And it provides a great deal of information. There's a downloadable app. It allows the patient to keep a daily diary, which is known to be very helpful to patients and families. Two-way communication of pain and basic needs when they're intubated, not able to speak. They can identify sites of pain and nausea, and it's available with multiple languages. And there's also been movements to facilitate creating a diary, because it can be very helpful for a family member to keep a diary of day-to-day events, especially for patients who develop delirium, which can be extraordinarily frightening, to actually go over with them afterwards what actually happened from day to day. It can help the patient to come back in touch with what was real and what was not. Our colleague, Shunichi Nakagawa, is a gentleman who trained in surgery in Japan and then came to the United States and switched to internal medicine and then underwent training in palliative care. and he is active at Columbia in palliative medicine in the intensive care unit, and actually participates in the evaluation of all patients who are potential candidates for a left ventricular assist device. And in the midst of the pandemic, he and a junior colleague came out with what I think is a very, very helpful protocol, which he called a 3-stage protocol for us as caregivers meeting with families when the patient is unable to participate. And he creates 3 stages. The first is to share knowledge. The second, clarify the goals of care. The third, negotiate treatment options. Share knowledge, clarify the goals of care, negotiate treatment options. So going into each of these in more detail, the first is to set the stage. Remember, we talked about the differences between team members. Very important to have a huddle ahead of time so that everybody in the team is on the same base and in agreement with what they're going to be presenting to the family. Choose a quiet, appropriate setting. Barbara Walters was treated at Columbia, and she actually provided funding for a beautifully quiet and comfortable room, which is called the Barbara Walters room, for us to meet with patients outside and families outside the intensive care unit. The first is to invite the family to share their understanding of the patient's goals and values. This is probably the most important point. And that the caregivers, the lead physician, should summarize the medical situation succinctly and within 2 minutes. So the 50% rule is never talk more than 50% of the time and listen more than so you speak. Share the prognosis in terms of what we are worried about, a functional outcome that we could anticipate, the trajectory and time frame. Is this going to be days, weeks, or months? Not giving percentages. And be prepared to address the family emotional responses with empathy. Share the knowledge. Clarify the goals of care, leading in with understanding the situation. What are you hoping for? What are you most concerned about? What would your loved one say? What conditions would he or she find unacceptable, either during their hospital visit or if they are able to survive the hospital and beyond? And then identify the patient's goals, values, and priorities while reflecting back the family's understanding and agreement by saying, does this sound right? The third would be negotiate treatment options. Integrate the prognosis that you have shared with the patient's goals and values that the family have shared back. Weigh the benefit and risk of each intervention in the context of an uncertain disease trajectory. In other words, is there going to be potentially a steady decline versus acute decompensation, which could occur at any time? Avoid yes and no questions. Avoid saying, do you want a DNR or not? Instead, make goal-based recommendations. So the best way to achieve your loved one's goal is hospice care focused on comfort rather than resuscitation. How does that sound to you? So that's a framework that I have taught and shared with my colleagues whenever I can. Dr. Nakagawa also came out with time-critical goals of care during the COVID-19 pandemic, kind of compressing this, and it gives a very good example of some of the specifics in terms of sharing knowledge. So, for example, if your dad gets a breathing tube and goes on a ventilator, it is much less likely that he will come home. Clarifying the goals of care. What makes your dad's life meaningful? What would he think of this if he could be talking to us now? Based on what we're hearing, staying independent and being with family at home are the most important things to your dad. Would it be okay to make a recommendation? Based on what we discussed, we'd recommend treating the pneumonia but not placing him on a ventilator if he gets worse. Does that make sense? So I think you're getting the picture of what Dr. Nakagawa is developing here, sharing the knowledge, clarifying the goals of care, negotiating treatment options, rather than saying, what do you want? Finally, when we get to a point where it looks as if a patient will not survive their intensive care admission, how do we help the patient to die with dignity? And Deborah Cook, who works in Hamilton, Ontario, has really been a thought leader in this area. And she came out with a wonderful article in the New England Journal of Medicine back in 2014, really asking the question of how can we assure death with dignity? And some of the principles that she pointed out is that we should focus on patient comfort as death approaches, understand the patient's unique perspectives or what gives life meaning, address the depersonalized ICU environment, and recognize the patient's vulnerability and inability to speak for themselves, and explain to the family what may happen when life support is withdrawn. This can be really important. For example, if a patient is on dialysis and the agreement is simply to withhold dialysis, the patient may very quietly lapse into a coma and die very peacefully. But if the patient is on a mechanical ventilator and the decision is made to discontinue that and take the breathing tube out, we need to explain to the family that the patient may be short of breath, suffer some distress, and we may have to provide medication for comfort and negotiate that aspect of it. If we go back to the issue of the Orthodox Jews who don't accept brain death, which can be a very difficult situation, there's a wonderful article here from the Journal of Religion and Health, which explains that the Jewish tradition to cope with death and mourning is very well established. And it is based on early separation of the body from the family with early burial within 24 to 48 hours, and then a very defined transition over days, weeks, months, and a year through the stages of mourning to try to help the family to cope. And I learned this, I'm not a Talmudic scholar at all, but what they mention in this is that there are some ancient teachings, what they call halachic teachings from the Talmud. So in Jewish religious observation, there are many things that one should not do from sundown on Friday to sundown on Saturday. So, for example, if you are walking along and you find a man buried under rocks through a collapse of a house on the Sabbath, that you are then permitted to actually clear the rocks until his nose is exposed. And if he's still breathing, you can continue to clear the rocks and rescue this man. If he's not breathing, then you can stop and walk away because he's dead. On the other hand, there is a second opinion, as there always is, that there are some teachings that would say, no, this is not enough. You have to complete clearing the rocks until you can evaluate the heartbeat. And think about that in terms of the difference of interpretation as to whether death occurs when the brain is not functioning and the patient's not breathing versus when the heart stops beating. And this helps to understand where this may come from. And the recommended approach in this particular article is to listen to the family's perspective and provide emotional support, to accept the notion of the Jewish sanctity of life. And this is common to other religions as well and other cultures. It's really important, but also to share limits of intervention and how in any kind of mechanical intervention has its limitations in prolonging life. Very importantly, separate talking about organ donation from brain death in this situation. And also, often what is accepted by a family is not to escalate therapy, not to go up on therapy, but maintain the current level of support with some sort of time point. We're going to reevaluate in a week or 2 weeks. In New York State, the individual hospital is allowed to set a time point for this, whereas in New Jersey, there is no set time point for doing this. But also, I think even Orthodox Jews understand this kind of gray area where between life and death, and that is something that one should try to share and engage rabbinical leaders into decision making, because there can be differences between the rabbinical leaders and how this is interpreted. There is another website that is worth exploring called the 3 Wishes Project, and this comes back to the project that I mentioned regarding the way that a family can set up the intensive care unit when their loved one is going to die. And this is how Deborah Cook outlines it. It's a set of wishes to honor the patient generated by the patient and family together with the medical team. The wishes are implemented before and after death, and they include humanizing the ICU environment by putting in family tributes, family pictures, and reconnections to the family, rituals and memorials for the patients, donations to their favorite charity. And the feedback that they have gotten from families is they say that this actually has personalized the passing of our loved one in the intensive care unit, because they dignified the patient and they gave us a voice. And we could see that the clinicians were compassionate about what was going on. So I hope that what I have covered, which is really just the tip of the iceberg, has provoked some thought, has given you some resources. And I'd leave you with this thought. This is a book that I've recommended to everyone that I come into contact with in the hospital, who I teach and interact with. And many of you may have read Atul Gawande's work. He's an endocrine surgeon who works in Boston. He's written some wonderful books. And I think one that made a great impression on me was this Being Mortal. And one of the things that he says in this book that really got to me is, we've been wrong about what our job is about in medicine. We think our job is to ensure health and survival, but really it's larger than that. It's to enable well-being. And well-being is about the reasons one wishes to be alive. So thank you very much for inviting me to talk today. It's really a privilege and a pleasure to be with you as a group.
Well, thank you, Rob. It is a privilege and a pleasure for us to have you here. And just to say one thing about Rob's participation in our ICU group is that he is, as you have gathered, extremely psychologically minded, and really, tends to that aspect of life. And that's such a big contribution, not just to our group, but really to the, to the medical community, I think. So I maybe will start off because I just wanted to say one thing, because you related to our group, we have blogs and have sponsored talks on some of the topics that you covered, such as moral injury, vicarious traumatization, and a few other things. I just wanted to share something, because my experience is working with people on chronic dialysis. I did that for a long time. And because you referenced the nurses, and they are really play such an important role. And there was one study from many years ago, specifically on dialysis patients, where they asked the nurses, would you be surprised? This is called the surprise test. Would you be surprised if this person died in the last 6 months? And their answer was highly predictive. No fancy tests, medical kinds of things, but just their gut sense of how long this person was going to last. So, Jen, maybe I'll turn it over to you now to do the Q&A, because
Sure.
I think there are some things in the chat, and you can also monitor the. I don't know if you, Jen, prefer that people write it in the chat or raise their hands.
Either way, but raising your hand, I'm going to go ahead and call on Janet, and I'll peruse the chat and see if I see some questions.
Dr. Sladen, I share Maureen's words. What a gift and honor and blessing it is to have you in our company. And thank you so much. You know, before, as we were preparing for today's meeting, we were thinking about the group, our work group was thinking about the emotionally evocative nature of your talk, and we were very mindful of that. And I have to say, your perspective of humanity and respect and care really is really what's needed and so golden. There are just two comments I want to make, and I love and I so appreciate that you highlight the moral distress, moral conflict, and even moral injury, not just that physicians, nurses, healthcare providers may experience, but the families themselves experience. You know, framing it as moral conflict puts it in another category in addition to the separate experience or the related experiences of guilt, sadness, shame, putting it in the context of moral distress that family members experience, I think so important. And the other thing that's implicit and that you highlight is that hope becomes, the notion of hope itself becomes redefined at this stage of life, where one is dying and saying goodbye to all that's cherished. And I think the notions of meaning and hope, even at this phase of life and of dying, are so crucial. And thank you, really. Thank you so much, Dr. Sladen. Really, people raved about you, but I never met you before. I wasn't part of the ICU group, but really, people have raved about you, and I could really understand. Thank you so much. We're so lucky. Thank you.
Thank you. A couple of things just to add. Obviously, perspective changes with age, and I say to my residents when I still do teaching and fellows that every physician needs to be a patient at least once. You have to understand what it's like to be a patient, and it's interesting when you're in, particularly when you're in the cauldron of the intensive care unit. It's almost like patients are have landed from another planet. They're a different species. We talk about us and them, and it is so important for us to put ourselves into the position of the patient, particularly in terms of empathy and comfort. And I try to lead by example of always going in and holding the patient's hand and asking them how they're feeling and letting them know that we're going to take care of them. I think that contact is so important. And having been a patient myself, I know how incredibly isolating it is being a patient, and especially, apart from the pain, discomfort, and everything else, it's not knowing what's going to happen next, and having physicians flit in and out at sort of unknown times during the day. I think that's something that we really lose sight of, especially under really dreadful circumstances. I think as I reached towards the end of my clinical career, I also started to think more about what happens to the patients when they leave the intensive care unit. Because if you're working in the ICU, the only time you see those patients again, if you're not a cardiologist or a surgeon following the patients up, you're an intensivist, then the only time you see them is if they get readmitted for some complication. Every now and then, family will come back and visit, and that's always a joyous occasion. I do have to mention Wes Ely, who is an intensivist who works at Vanderbilt, and I've put the group into contact with them because they have really been the ones that have defined what is called the post-intensive care syndrome, of patients who are able to get out of the intensive care, whose life is never the same again, and who may suffer cognitive, physical, psychological disability for weeks, months, or years. And they've actually set up a post-intensive care syndrome clinic where they see folks with the help of psychologists, psychiatrists, social workers, nurses, and they really try to give them help and support. And I think that that's something that should become part of our overall medical care.
Evie, would you like to ask a question? You're on mute.
you, and thank you for both a riveting and wonderful presentation. And I can only mimic and just say that Janet's words really capture the felt sense of your presentation and of you. So we're having an embodied experience because you do represent that, and your sensitivity, especially to cultural differences, is really something that caught my eye. When you mentioned about the Jewish tradition, it's also the case that when somebody dies, the regular hospital staff is not allowed, if it happens though, to remove any of the connections that because of blood issues. And there's a whole big understanding of that. But if a physician doesn't know that and doesn't understand that, and they're caught without someone to negotiate that, it can be very problematic. And the brain dead piece that I was just thinking, I'm in Jerusalem, by the way, and that's where I live right now. And Rabin, no, the other person, I'm blanking on his name. There's so many names to remember here. But he was the prime minister, and he was hospitalized. And basically it was a question of brain death. But in Israel, you're not allowed to do anything about that, even sometimes with the family's request. So it's really to know the cultures, to understand what it is, and the way you presented yours, it's a wonderful, full experience. So thank you again.
Evie, I think it was Sharon you meant.
Sharon, yeah, thank you. Right now I have brain fog galore here.
Yes, don't we all?
Yeah. So thank
So
you.
we have a question in the chat from Amy, and she asked, how can we help families whose loved one who needs care wants all measures to sustain their life when their family is strained financially and emotionally?
Yeah, that's a very
It's a team.
Big question.
difficult situation, obviously, but I think that it's important for one to take the approach that is supportive as opposed to confrontational. It's sometimes we can get upset with families, and that can actually be expressed in our body language and our interactions. We always have to try to listen rather than speak. And I think one of the important things is to try to figure out where that person is coming from. Is there anger? Is there guilt? Sometimes if the family is angry with the care that the patient's been given, that can actually temper their approach. So I think all one can do in this situation is try to listen to that loved one, see where they're coming from, and then again try to get a sense of how well and how close they are to their loved one, and whether they have a sense of what their loved one would want. Would they want to be in this situation? Are we keeping the patient alive because that's what they would want, or is it because of what you need and want? Is the way that we have to try to figure this out. But I think the important thing is to recognize that ultimately there is going to be an impact not just on the patient, but also on the caregivers that are taking care of the patient. And so it really has to be something where one brings in an ethical consult. I've worked very closely for many years with Ken Prager, who's going to be your speaker at the end of May, who is a pulmonary physician who has been chair of the ethics committee at Columbia for many years and battled with these kinds of situations. But I would not try to do it on one's own. I think one has to bring in ethics and any other help that one can in terms of trying to persuade this loved one that you know, ultimately this is not going to make any difference to the outcome. And again, I think it may be more practical to talk in terms about limiting therapeutic escalation as opposed to withdrawing therapeutic escalation, even though I said ethically they may not be interpreted as being any different. So I think people can accept that we're not going to add anything on, and we're not going to go any further, or if there's a new complication, we won't treat it, and set a time interval. You know, we'll reevaluate this in a few days as we go along, as opposed to saying we're just going to take everything off.
Any other questions? Any? Okay.
Okay, well, ending really just on time. So I really, again, I can't thank you enough. I do want to put out something I didn't mention when I was going through the, you know, what we do is that we are ongoing, and if people have any questions, you can send it to really any member of our group, but my email address is coronapsych20@gmail.com. That's corona, like the virus, psych, like psychology, 20, like the year it started, and at gmail.com. So if you have any questions, but also if you might be interested in joining our group, you know, one of the or the other subgroups, or, you know, even just to talk about that possibility. So.
And June has her hand up.
Just a
Oh.
very quick question as we're ending. I also thought it was an incredible presentation and such a rich amount of information, and thank you so much. I did see that Jen noted in the chat that there would be the recording available for those of us who were participating, but there was also the question about the availability of the slides, and I would understand if if Dr. Sladen, you didn't want to share those, but it would be something that I would be interested in finding out if you would be willing to share those slides. Thank you so much.
I have one quick question that's been very much on my mind throughout listening to you. Rob, do you think that medical schools and educational systems are in any way changing in the direction of being able to have this more compassionate, more open-minded, more collaborative approach to what happens in the hospital, in ICUs, and that helps all of the staff and all of the families and all of the patients?
Yeah, that's an interesting question. I think there's a lot more awareness today, particularly since the pandemic, of the impact on caregivers and physician burnout, in particular nurse burnout. You know, there's as I think everybody knows, there's a dramatic shortage of nursing personnel throughout the country because of resignations and change of kind of venue, moving out of the intense hospital into more outpatient facilities. So I think hospitals are much more attuned to that, and there's certainly are increasing sense of the importance of resources being made available, psychologically, psychiatric resources, team resources for trainees in you know, in the environment.
Mm-hmm.
How that translates into interaction with the patients and families, that's another issue.
Mm-hmm.
But you know, I think hospitals have really recognized the financial impact of not being able to have adequate staff to take care of patients, and that's really one of the drivers at this point in time. I think in terms of how we interact with patients, for the time being, it's still going to be very much a kind of a mentorship approach that we have to spread the word among ourselves and act as role models for our trainees. I don't think that we can expect that there's going to be something that's laid out, you know, in any way. We've been going in the opposite direction for a long time because of all the pressures and constraints and the competitiveness that drives medicine in the United States and the other countries as well.
Thank you. Thank you very much.
Anyone else?
Well, I was just reading in the chat, Lester referenced Rita Sharon's narrative medicine, another person who's at Columbia, as a step in the humanistic approach to care. And that is absolutely right. She talks about getting to know the patient's story.
Yes.
But again, it's the conflict, right? There's not time to really get to know the person because of all the pressures. On that topic, the issue that Rob just mentioned about burnout among nurses, that is our topic next week. We have two psychologists who are both clinicians and researchers from the University of Toronto, Bob Maunder and John Hunter, who have done a lot of work on attachment and the relationship of attachment style to medical behavior of all types. Their focus for next week, though, is going to be on research that they did during the pandemic. And I think it focuses mostly on nurses, but I'm sure there are elements that are generalizable, and about interventions for burnout, which is really important. And then the last one on the 31st, Ken Prager, as Rob mentioned, the corporatization of the field of medicine, which does contribute to all of these things, including not having time to spend with the patients to do all these things that are so important. So love for all of you to come back for those. Janet, did you have?
Yeah, I did, and I feel bad throwing this out at the last minute, and I know we can't answer it, but talking about difficulty ending, right? The difficulty ending, but I'm just going to put it out there because I forgot about a question that I had, and I know we can't answer it now, but I'm just going to put it out there, which is how healthcare practitioners' fears of lawsuits actually may impact all that you've been talking about. And I don't know why it came to me at this last minute as we're about to end, but we'll just have to table it for a future discussion. But I think that's also such a critical factor, right? The fear of lawsuits. And I love that part of the decision-making process that you've talked about is always consulting with ethics committees, right? To make sure, but I realized I had that question way before and I forgot all about it. So I know we can't deal with it now, but just putting it out there. But Dr. Sladen, thank you again. Really, I mean, as everyone said, beyond words.
Okay, well, terrific. And I hope to see many of you here next week and on the 31st. Okay, take care. Bye.
Bye-bye.